Hi, I'm Dr. Jacob Sands. I'm a thoracic medical oncologist at Dana-Farber Cancer Institute, where I lead our small cell lung cancer program, our clinical and clinical research program for small cell lung cancer. Welcome to this peer review educational activity focused on important treatment advances in small cell lung cancer and relevant implications for clinical practice. We're going to go all through a discussion about small cell lung cancer from the first line and beyond, and I am looking forward to discussing this topic with all of you. So Module 1, we're going to focus on surveying the current state in the treatment of small cell lung cancer, key challenges, expanding therapeutic options, and current guideline recommendations. But first, let's start with diagnosing small cell lung cancer. This is diagnosed by a tissue diagnosis, like much of cancer. Most cancers follow the statement, tissue is the issue, and that's certainly true for small cell. There are standard immunohistochemical stains for the diagnosis. The majority of them express TTF1, and 75% express neuroendocrine differentiation, with stains such as synaptophysin, CD56, and chromogranin. Small cell lung cancer has a very high mitotic rate. It is a transcriptionally active cancer, so it grows quickly. It's clinically aggressive as a diagnosis, and this is one of the challenges in treating it. We'll get to that when particularly when we're talking about second line and beyond, where it's really important to get responses to therapy. Now, the management of small cell lung cancer is challenging because of the aggressive nature of the diagnosis. And so for historical context, a lot of survival curves that we see really have a pretty steep slope down. And this is certainly something that we still see in some of our curves today. So when looking at the barriers to treatment advances in small cell lung cancer, there are a handful of things, and they're outlined here on this slide. Smoking-related cancer, and therefore many of these patients have other comorbidities. Certainly having some degree of lung function being affected with COPD can be challenging because patients have less lung function, and therefore as their tumor volume increases or challenges that, as I mentioned, these patients can end up having an oxygen requirement earlier on. But on top of that, cardiovascular and other comorbidities are certainly can exist, particularly with a significant smoking history. The fact that it is rapidly progressive means that really any delays in getting started can be really detrimental. And so in many cases, we're starting treatment as quickly as possible for small cell lung cancer. And in the second line setting and beyond, if there's a treatment option that's not effective, then they really may lose the opportunity for other treatment options. And that's going to affect some of our discussion of second line and beyond treatment. The fact that there's limited tissue that is viable at the time of biopsies, there's often, when we have biopsies, it's often that there's some necrotic tissue, and so the plentiful biopsies that we get in non-small cell lung cancer and other diagnoses are not always the case for small cell, and so we don't have as much tissue for some of the preclinical work like what we get in non-small cell lung cancer. So this is a diagnosis that fortunately we have a nice rapid response in the first line setting, but second line and beyond gets quite a bit more challenging, and we're going to dive into some of the details of that. Looking at the tumor mutational burden, the further out to the right you go in this chart, the higher the tumor mutational burden. And so you see melanoma all the way out there on the right. And melanoma is where we have really seen a lot of the immunotherapy stuff start, and we get better responses in that. The further left we go, then we have decreasing mutational burden. But you see really non-small cell lung cancer is still quite a bit out there on the right, and small cell lung cancer as well. Now, small cell lung cancer has some very common genomic alterations as well, particularly P53 mutation and RB1 loss. And both of these, you see on the slide here what those genes normally do, and they're essentially like brakes to the cell cycle replication process. And so when the DNA has multiple mutations in it, these help to halt that process to repair the DNA. So in the process of replication, we end up with cells moving forward that do not have these different mutations. But when these are mutated, when we have RB1 loss, then it's kind of like the brakes being broken. MYC, on the other hand, is something that helps to push the process forward to activate expression of genes that enable proliferation. And it's about 20% of small cell lung cancer has amplification of MYC. And in this case, it's kind of like the gas pedal being pushed down. So when you really have all these together, the brakes being broken, and then in some cases also the gas pedal being pushed down, this is really what further pushes these cells into such aggressive action. Now, when we look at the NCCN guidelines, we see here this is for limited stage disease. Limited stage disease, the treatment is with curative intent. It's concurrent chemotherapy with radiation. And you'll notice here that with a performance status of 0 to 2 or performance status of 3 to 4 even, using concurrent chemoradiation is still the preferred if it is considered tolerable. You'll notice that with poor performance status, ECOG 3 to 4, is concurrent or sequential. Basically, sequential is if you really don't think the patient can tolerate concurrent therapy. But this is unusual. In a lot of cancer diagnoses, when you have such a poor functional status, then you're really talking about more supportive care. But in this case, the diagnosis can be so rapidly progressive that even patients with a baseline good functional status can end up with a poor functional status. And it responds quickly enough to treatment that patients can also go from a poor functional status back to a good functional status fairly quickly. You'll notice there at the bottom, though, that a poor performance status that is not due to small cell lung cancer is where you're probably looking more towards supportive care. And I've had, it's rare actually, where I have a patient with a new diagnosis of extensive stage small cell, let alone a limited stage, where we don't end up giving therapy. But one example is a patient of mine who had such poor COPD, really end-stage COPD, where she was in a wheelchair. She didn't feel like she could do much at baseline before ever getting a diagnosis of small cell. And in that case, she said, hey, I wasn't able to do enough to really have any quality of life before even getting this diagnosis. And of course, that's a different scenario. But a strong point here is that this is curative intent treatment when you're looking at limited stage disease. Now, extensive stage is still, even with a performance status of 3 to 4, giving systemic therapy is something that can be done. The most extreme example I have is of a patient that actually I saw who was in the intensive care unit. He was intubated. He'd actually been there for more than a month because he had had a post-obstructive pneumonia as an initial component of his diagnosis. And so he was there and getting antibiotics and got treated for that. And actually, I was consulted more than a month into his time in the unit. He had a trach, he had a G-tube. He wasn't really able to move his left leg at the time. He was really in about as poor a performance status as one can have, but at his baseline actually had been a good functional status, but in this point, really severely limited. And we had a discussion about his extensive stage small cell lung cancer. He had said he really wanted to go home for a day and then come back even, which of course we said that's not really how this would go if he went home given his oxygen requirement and vent status. So he decided, okay, well, you know, no promises, but I'll give it a shot and we'll see what happens. And actually I treated him in the hospital. And for his second cycle, he came in on a stretcher from a nursing facility, but was no longer on the ventilator, and G-tube was taken out, and cycles 3 and 4 came in a wheelchair. And then after that was using a walker, but insisted he didn't need it, and he would walk around the office holding his walker up, but was walking miles a day, and really got back to his prior life and his prior functional status. And it's exciting to see that in the first line setting, and then second line and beyond is quite a bit more challenging, but we'll get to that. You'll notice here it says combination systemic therapy, and combination being platinum etoposide plus atezolizumab or platinum etoposide plus Dervalumab, and we'll focus a bit more on that as well. Well, you'll see in the second part there, it's extensive stage disease plus localized symptomatic sites, and it gives some examples there. Now, radiation can be considered in some settings. But the thing is that systemic therapy tends to work so quickly and so effectively that if I can get somebody started on their systemic therapy, then often I'll try to do that. Spinal cord compression, some of these emergencies, you really have to weigh out the specifics of the scenario, and this is where it becomes a multidisciplinary effort. Now in the relapse or second line and beyond setting, you'll see performance status there of 0 to 2 is subsequent systemic therapy or palliative symptom management. Palliative symptom management, these are not mutually exclusive, so it could say and or. And you see, well, we'll get into some of the systemic treatment. I think what this is showing is just that there are other options, and so to continue those in patients with a functional status that allows for it. I will say that, performance status 3 to 4 in this setting by the guidelines really say palliative symptom management, localized radiation, symptom control, not really including systemic therapy. But individual management, there are some patients where it does make sense to give them systemic therapy, and so it kind of depends on the patient and the scenario. When looking at the specific systemic therapies, we see these here. The preferred regimens there at the top, cisplatin etoposide. This is for limited stage disease. Cisplatin etoposide, there are 2 different dosings there, and that really is dependent upon whether you're doing radiation daily or radiation BID. When talking about extensive stage disease, the standard of care now is to include either atezolizumab or durvalumab. The way the studies were done, you'll see on here that atezolizumab is carboplatin and etoposide. With durvalumab, there's cisplatin or carboplatin and etoposide. I tend to use carboplatin in the extensive stage setting, and so carboplatin, etoposide, and a checkpoint inhibitor. Now, when looking at subsequent therapy, here we see a split on the NCCN guidelines. And on the left there is relapse in less than or equal to 6 months. And I should clarify that this is the chemotherapy-free interval. So this is the time from having completed the chemotherapy portion. If the patient is getting carboplatin, etoposide, and a checkpoint inhibitor, they might still be on the checkpoint inhibitor, but we're talking about the time since the last treatment with carboplatin, etoposide. In less than 6 months, the preferred regimens are Topotkin, either PO or IV. I should point out that the FDA approval for those is at a 45 or 60-day chemotherapy-free interval, respectively. Lerbin is more recent with an FDA approval in the second-line setting, and that comes from a 105-patient basket trial that did not have a limitation on the chemotherapy-free interval, and therefore the FDA approval does not specify. And then also importantly, clinical trial. And the fact that clinical trial is a preferred regimen really highlights how challenging this setting is. We're going to go into some of the data of Topotkin and Lerbin as well as others. And although these are advances and although these are important treatment considerations, we'll also see that it's important to really try and develop more options for patients, and there is certainly a need. And so clinical trial needs to be a strong consideration in the second line setting and beyond. I'm going to jump over to the right side here of a relapse greater than 6 months. Again, this is chemotherapy-free interval. And in that setting, retreatment with platinum etoposide. And here it says original regimen, but at another point within the NCCN guidelines, if a patient is progressing on a checkpoint inhibitor, that checkpoint inhibitor is really not continued. So in this setting, we'll be going back to platinum etoposide is the recommendation. Now, there are other treatment options within this list that we're going to discuss. Paclitaxel, we will discuss. Irinotecan, I tend to use more than Topotkin, and so that's another one for consideration. Temozolomide, particularly for the fact that it crosses the blood-brain barrier, and so especially when there's CNS progression, that's a consideration. Now, Nivolumab and Pembrolizumab are also on this list, and you'll see that down there. despite the fact that both of these drugs, the initial FDA applications were pulled based upon some negative studies. That being said, I think that these are still really important treatment considerations. And so for patients who have been treated for limited stage disease, or for whatever reason didn't get a checkpoint inhibitor in the first line setting, this is certainly something to consider at later line settings. And we'll look at some of that data. These drugs, unfortunately, don't work for everybody, and it's a fraction of patients that really benefit, but those who benefit can have really impressive, durable responses to treatment, and therefore these need to be a consideration. Again, if a patient has been treated on a checkpoint inhibitor, these are not a consideration, and that is highlighted in the NCCN guidelines, but I want to make it very clear given what we're showing here with the slide. Now, in Module 2, we're going to explore the evidence supporting the use of current therapies, key ongoing trials, and promising emerging therapeutic approaches. And there's a lot to discuss here. So first of all, going into the first-line setting, we've already highlighted that inclusion of atezolizumab or Dervalumab with platinum etoposide is important, and we're going to discuss some of that data here. So first of all, atezolizumab was included in the Empower 133 trial, carboplatin etoposide with atezolizumab or a placebo. This was included for 4 cycles of chemotherapy with the checkpoint inhibitor, and then maintenance with the checkpoint inhibitor or placebo. And within this trial, the median progression-free survival benefit was 1 month, which is not shown here, but the 2-month, the median overall survival difference was 2 months. Now, this is where I think talking about the medians doesn't really highlight the true benefit from the drug. And so a median difference of 1 month progression-free survival in itself, I wouldn't say is particularly clinically meaningful. But the most meaningful thing about this is really looking out on the tail of the curve and the number of patients with ongoing disease control as we get further out. And we see that on this overall survival curve as well. Here, we see a separation at 12 months going from 39% to 52%, and at 18 months from 21% to 34%. And so there's really a subset of patients that are getting particular benefit from this drug. And when looking at the safety data, fortunately, these checkpoint inhibitors have not added too much to the toxicity profile. And we see that within the immune-related AEs, certainly there is an increase. Most patients really tolerate the therapy well, and we do have people that need to stop the treatment due to the severity of rash or diarrhea or even pneumonitis, which is the one that particularly concerns me the most in this population of patients with that often have poor lung function to begin with, as we mentioned. Now, looking at the concurrent chemotherapy with Dervalumab study, this included, one could choose either cisplatin or carboplatin, hence what we discussed earlier on the NCCN guidelines. This was a study that looked at 3 arms. So it was chemotherapy plus Dervalumab, chemotherapy plus Dervalumab and tremelimumab, or just the platinum etoposide itself. Now, the way that the study was done, we'll look at the curves, but the meaningful part really was the Dervalumab plus platinum etoposide, and that is, in fact, what led to FDA approval. But you see this schema here. And here is the 2-year overall survival update. Again, we see separation of the curves. Now, there's not a formal analysis of the Durva and Tremi, and so we're not really discussing that within this setting. But you'll see that all 3 are there, and with the platinum etoposide plus Dervalumab, we do see a clear separation of these curves as we get further out on the overall survival curves. It did lead to a 2-month improvement in the median in the median overall survival. There was no real difference in the median progression-free survival. But again, I'll make the point that the median is really probably not the right outcome to look at with these drugs because there's not a dramatic difference in them. The median is something that, by definition, 50% of patients have had less than, and 50% of patients have had more than that time point. And as we get further out on the curve is where we really start seeing the bigger separation of those, in that these drugs really help to have prolonged and durable progression-free survival. And the patients that I've been following the longest with small cell lung cancer in many cases are people that really have had ongoing years of benefit from a checkpoint inhibitor. And in some cases, these are patients that were included in clinical trials in the first-line setting and therefore really are truly years out. And in some cases, actually, these are patients in the second-line setting getting a checkpoint inhibitor. But we'll get to that setting. But it's an important point to make that with these immunotherapy drugs, it's not effective for everybody, and therefore the medians don't really tell the story. But those who have a response, this can be a home run drug in those settings. And here we see the overall survival curve in the 3-year update from Caspian. And this further highlights the point I'm making about the durability of responses. And we see out at 3 years, a clear separation at 17.6 versus 5.8% of survival. The safety data, similar to what we saw within the Empower 133 study, generally very well tolerated, certainly an increase in immune-related AEs, but like I've said, in many cases, this is tolerated. Patients can get, as I mentioned before, rash, diarrhea, or pneumonitis, as well as, of course, there are others, but those are some of the more common and the more concerning. In most cases, that really just responds to a steroid, and in some cases, that can require months of prolonged wean, but fortunately, that is not the norm. And when that happens, in most cases, patients really do get better. And in many cases, I think I see patients rapidly get better once we start the steroid. But these can be reasons to not be able to continue that checkpoint inhibitor further. And so if they've had a really severe reaction, then of course that can lead to stopping the drug. I will mention, within this, you see the Tremelimumab. This is a CTLA-4 inhibitor. We're not really diving into those outcomes, but you do see an increase further in the immune-related adverse events. And so just as far as a drug looking forward or a class in considering, this I think is one of the challenges. So for first-line treatment, chemo immunotherapy based on Empower 133 with the inclusion of atezolizumab and based upon Caspian with the inclusion of Dervalumab, both of them meaningfully increasing the median overall survival, although really the point is actually out on the tail of the curve where we see patients that really have long-term durability of the treatment. So now we're going to get into the second-line therapy, and this is where things get a bit more challenging. So we've already discussed the NCCN guidelines here. I will highlight again, we're going to dive into a bit on Paclitaxel, a bit on irinotecan. We'll touch on temozolomide, and then the single-agent pembrolizumab and nivolumab are only in the setting of not having previously gotten a checkpoint inhibitor. Of course, we'll also talk about the 2 FDA-approved therapies, being Topotkin and Lerbin, as well as looking at repeating treatment with platinum etoposide in those with a greater than 6-month chemotherapy-free interval. Now, this is a look at that, although I should point out that this trial itself was done in Europe, and so this was in patients with a greater than 3-month chemotherapy-free interval. And looking at platinum etoposide in that setting, retreatment versus Topotkin, we do see separation of the curves here, although this really did not result in a significant overall survival difference. And so we see really a lot of these curves are almost on top of each other as far as overall survival. Now, lurbinectedin, more recent FDA approval in the second-line setting, and this is a look at some of the mechanism of action. And we've previously discussed that in small cell lung cancer with P53 mutation, RB1 loss, and 20% of patients having MYC amplification, this is a very transcriptionally driven tumor, transcriptionally active cancer. And lurbinectedin binds to DNA promoters. The binding of transcription factors is prevented, and it therefore leads to cell apoptosis in that process. At the same time, it actually has an a mechanism within the tumor microenvironment as well, and it can result in apoptosis of tumor-associated macrophages, which are, at the first hand, sounds like it would be meaningful, that you'd want immune cells there. But in fact, these tumor-associated macrophages actually lead to increased angiogenesis of tumors, and can actually end up inhibiting some of the responses in that setting, as well as angiogenesis obviously leading to vascularization of tumor. And so by leading to apoptosis of these cells and clearing some of these cells from the tumor microenvironment, this may in fact have an important therapeutic effect in the treatment of small cell as well. Now, that's an area that requires further ongoing research, but another compelling aspect to the mechanism. So in the second line setting, this is the Lancet Oncology publication that led to FDA approval. This defined resistant versus sensitive disease as a greater than or equal to or less than 90 days from the time of completing last chemotherapy. That being said, all patients could enroll. There was no restriction on the chemotherapy-free interval. This was a 105-patient basket trial. It was a single-arm study. And when we look at the outcomes from that study, this is kind of a busy chart, so we'll put a box here to really focus specifically on the median progression-free survival as well as some cut points there. And you'll see that the median progression-free survival of the whole population was 3.5 months. Not surprisingly, with lurbinectedin being a chemo agent, those who have more resistant disease did worse than those who had more sensitive disease. And we see that with a median progression-free survival in the resistant group of 2.6 months and in the sensitive group of 4.6 months. Now, as I said earlier on, this really, I think, highlights the need for clinical trials and the fact that the median is still quite short. And so not everybody is benefiting in a very durable way with this drug, but there certainly are those who are benefiting, and I think we see that best within this 6-month progression-free survival. So a third of patients overall are getting at least 6 months of disease control, which I would argue is quite meaningful in this very challenging to treat disease setting. Only 19% of patients in the resistant disease are experiencing that, but this is a diagnosis with a terrible prognosis, and to get 6 months of disease control in that setting, I would say, is especially meaningful, but it's only 19% of patients that are getting that. On the other hand, in the sensitive setting, we're seeing about 44% of patients with ongoing disease control. So 6 months, quite a few more are getting that durability in the sensitive disease setting, which is what we would expect, and I think is quite meaningful in both of these, but does highlight the fact that we need to do more. Now, that being said, we look at overall survival. This kind of fits similarly as we would expect, and so the median being 9.3 months, 5 months in that very challenging resistant disease setting, and about a year in those with platinum-sensitive disease. And we see that also in the 12-month median, or the 12-month overall survival being about a third of patients living a year, and 16% of patients in the resistant setting, and 48% of patients in the sensitive setting. So following what we would expect, I think this is important treatment, and there's a subset of patients in each of these that are really getting some durability relative to the disease setting. Resistant disease is a horribly challenging setting. And I'll point out, this is resistant disease being less than 90 days, and the only other FDA-approved therapy is Topotkin, which really was initially studied at the 60-day cutoff, and then with PO at 45 days. But to dive a little bit more into the outcomes with lurbinectedin, we see here the duration of response, and note that the time points on the bottom of these charts is not following the same scale, and so the shape of the curves can be misleading if you're not looking at that. But this shows what we've just looked at essentially. And then on the right there is the swimmer's plot. Now in the swimmer's plot, you'll see that on the left side of that swimmer's plot is where you can see that duration since the last chemo. So the chemotherapy-free interval is there. So the patient at the top was 5.8 months. So this is the less than 6 month chemotherapy-free interval with, in this case, 15 months of disease control. Of course, that still fits in the platinum sensitive by definition in the trial, but it is less than the 6 months by what we talked about with the NCCN guidelines. And you'll see here in the light blue, these are those with the resistant disease, so less than 90 days of chemotherapy-free interval. And the top one here is actually really less than a month. So this is a patient that wouldn't really fit the FDA approval for Topotkin, that did get a good 9 months of disease control with lurbinectedin. Now, it would be misleading to pick out only the best cases and suggest that that's how it is for each patient. And of course, we do see patients further down within the swimmer's plot where it's limited as far as the duration of disease control. Not all of these patients had progression. This was just the time point at the data cut. As far as safety, fortunately, lurbinectedin is generally well tolerated. I think there are a few things to highlight. One being the neutropenia. So a good percentage of patients really had grade 3 or 4 neutropenia. You see 21% grade 3, 25% grade 4. Fortunately, only 5% of patients had febrile neutropenia. I should also highlight that this study did not allow primary G-CSF prophylaxis. So that's something that certainly could be done in clinical practice, but was not done within the study. And had it been done, presumably that neutropenia would have been less. The other one that for me is maybe a little more concerning, but fortunately far less frequent, is fatigue, and so I've highlighted that here. Patients don't really feel neutropenia. Of course, they feel febrile neutropenia. Patients end up admitted to the hospital, and that was 5% of patients. But the patients that are having grade 3 or grade 4 neutropenia with no other complications don't feel that. But grade 3 fatigue is something that they obviously do. And when I first saw this data, it seemed that, well, maybe this would be more patients who had progression on small cell, because of course small cell lung cancer causes fatigue. And it's hard to know what percentages these were, although of course, this may have been attributed to the drug, but when you're treating a patient, it can be hard to know for sure sometimes. But it certainly is something that I've seen in practice. And in the worst case scenario, I had a patient who had a really nice response to the treatment, but had such a degree of fatigue that we really had to hold the therapy. And even with holding it, he really had another 4 months of ongoing disease control after having had really rapidly progressive disease. So I feel very confident that he was certainly benefiting from the drug and really had some durability even after stopping it, but the fatigue was severe enough that we really had to stop it. Now, although we've just talked about the data that was compelling that led to FDA approval of single-agent lurbinectedin, unfortunately, the Atlantis trial looking at combination lurbinectedin plus doxorubicin was not a positive study. And this was, you see the schema here, this was a comparison of combination doxorubicin plus lurbinectedin to either Topotkin or CAV. And the trial was a negative trial. I'll point out that the dose of lurbinectedin within this combination was less than what was used in the single agent study, but of course was combined with doxorubicin. But I think suggests enough that there's not synergy, or certainly not enough synergy to be a reason to treat with that combination versus either Topotkin or CAV. That being said, there are now further studies that are ongoing and others that are planned. I'll highlight the Lagoon study, which is evaluating lurbinectedin either in combination with irinotecan or as a single agent, and then both compared to investigator's choice of Topotkin or irinotecan. And this is in patients who've progressed with small cell lung cancer after prior platinum-containing chemo, either with or without a checkpoint inhibitor. There are an array of other studies as well of lurbinectedin plus immunotherapies, and you see that listed there on the bottom. Now, Topotkin is the longest standing FDA-approved therapy, and as mentioned, there is a PO as well as an IV regimen, and you see the dosing there. And these are the studies that led to approvals. We just talked about the lurbinectedin plus doxorubicin study that was negative compared to either Topotkin or CAV. And you can see on the right there, the FDA approval for lurbinectedin was, or excuse me, the FDA approval for Topotkin came from a Topotkin versus CAV study, in which case it was a negative trial. And those curves really are on top of each other, but the Topotkin was better tolerated and therefore was approved. On the left there, you see Topotkin PO versus best supportive care. And in this setting, this is from 2006, so it's actually quite recent to be a study that has a best supportive care control arm. But I should point out that this is in patients with a worse functional status, and therefore that was why that was done. But this did lead to FDA approval as well. And we clearly see separation of the curves, although we'd really like to see more separation in a study that's using best supportive care as the control arm. But this further highlights the very challenging clinical scenario here. As far as the toxicities, you see here the oral Topotkin as well as IV Topotkin, and really cytopenias are very common, and we see not just neutropenia, but thrombocytopenia, anemia across the board. Diarrhea is more common in PO, not surprisingly. Fatigue really occurring in both at about 6.5% of patients having grade 3 fatigue. And now we're going to look at some other second-line options. Now, I've mentioned that I tend to use irinotecan rather than Topotkin, actually. And so here, this is irinotecan, another topoisomerase 1 inhibitor. The mechanism of action is that it prevents religation of the cleaved DNA strand, leading to DNA damage and cell death. Now, the data from these other studies is, this is older data. You see this is a publication from 1992. These are commonly used drugs. They're within the Nccn Guidelines. They do not have an FDA approval. And the data from these older studies is quite limited in numbers. And so in this study, this was only 15 patients. You see that about half of them, 7 patients, had a partial response. This included limited stage disease as well. And the median duration of response is reported in days, which of course highlights the very challenging scenario when we're talking about days. But it is well tolerated, and you see here on the right the side effect profile. With irinotecan, I'll say, diarrhea, of course, is a unique toxicity to irinotecan versus some of the other chemo agents. This is one that I think most patients tend to tolerate well, but that is a unique side effect to look at. Now, Paclitaxel, Paclitaxel's mechanism of action is that it binds to microtubules and essentially preventing disassembly of them. And this is what inhibits cell replication, interfering with late G2 mitotic phase. And so ultimately that ends up leading to cell death. And Paclitaxel can be dosed 2 different ways. One is by Q3 week dosing, and you see there the 175 milligrams per meter squared on the left. And on the right is weekly dosing for 6 weeks of an 8-week cycle. So 6 weeks on, 2 weeks off. And you see the outcomes here. I'll focus on the right because I tend to do more of the weekly dosing. And so this is 21 patients, 11 of them with platinum-sensitive disease and 10 with platinum refractory. And you'll see that the partial responses, the response rate on the right there, so 20 to 27% depending on refractory and sensitive disease as far as response rate. I find that particularly the weekly dosing is very well tolerated for patients. And as we get to this setting where not everyone's going to benefit, And when they don't benefit, the disease can be rapidly progressive and the prognosis is very poor, that using regimens that end up not causing much in the way of toxicity is reassuring, in that at least I'm less likely to be hurting somebody. If the therapy is not working for them, then certainly I'd hope to really not add much in the way of side effects if they're not going to benefit from the drug. Of course, I prefer that everyone benefit from the drug, and I wouldn't use a drug if I didn't expect a reasonable possibility of them truly benefiting from it and from it effectively treating their cancer. But unfortunately, in many cases, that doesn't happen. And so to at least not cause toxicity becomes more and more compelling in that case. Temozolomide is another one that's often well tolerated. As I mentioned, this does have a good penetration of the blood-brain barrier. Temozolomide is a prodrug, and this rapidly converts to an active metabolite that essentially leads to DNA damage and apoptosis of the cells. The fact that it crosses the blood-brain barrier, to me, is really the most compelling part of this drug. But here we see a waterfall plot of outcomes. And so, similar to others, it's not everybody that benefits from this drug, but there certainly are patients out there further on the right side where we see deep partial responses, and even one complete response was noted. This study defined platinum sensitive versus refractory based upon a 2-month cutoff. And you'll note there on the right that R in the chart is patients who were refractory. So some of these patients really having deep responses despite having had platinum refractory disease. Now, the response noted itself, of course, is not the full story. It's the durability of the responses that clinically matter most. And you see here, like we've seen with all of the chemo drugs, really, is that those who are more platinum sensitive are more likely to have some durability and some responses. Again, I'll point out that the scale is not the same on all of these charts, and so just looking at the shape of the curve in comparison can be misleading. Fortunately, temozolomide is generally very well tolerated, and more recently there's a study looking at a 5-day regimen as opposed to the 21-day regimen. And you see the dosing there at the top of the slide across the two of them, and the toxicity as well. And the 5-day study, one of the conclusions from that was that this is a better tolerated regimen and therefore might be more useful going forward. And I'll point out a couple things in this. Now, the outcomes are considered similar, and the response rate between them within the classic 75 milligrams per meter square per day for 21 days of 28. Within that regimen, the response rate was 20%. Within the 5-day regimen, the response rate was 12%. But the number of patients with platinum-sensitive disease was a bit more plentiful in that 21-day dosing study. And so the classic dosing regimen did have patients that seem to probably be more likely to have responses as well. And so it's harder to know what to make of these differences. But I generally, my practice is more to use the classic dosing in patients where I'm not concerned about any issues of tolerating the regimen, and in someone where I'd be more concerned about that, particularly the cytopenias, really is the 5-day dosing. And now we're going to discuss some of the future directions, and one of those really is small cell subtypes. And this is looking at 4 different receptors we can see by staining: ASCL1, NeuroD1, YAP1, and POW2F3 is one. This comes from Dr. Charlie Rudin at Memorial Sloan Kettering. There's also a very similar subtyping that was really proposed out of Dr. Lauren Byer's lab at MD Anderson. And what this suggests is that what we've been categorizing as small cell lung cancer, we may actually be able to subcategorize, much like what we've done with non-small cell lung cancer, in that we now have squamous cell and adenocarcinoma. But with small cell lung cancer, this looks like it might also be a bit more fluid. And so it's not entirely analogous to non-small cell lung cancer. But what it may provide is a framework within which to take some of these novel therapies that are being developed, and there may be subtypes that respond better to some of these different drugs. And so one example of this, which we'll discuss, is PARP inhibitors, for example, have shown some promising results, but the studies have been negative. Although when looking at Schlafen-11 expression, that really seems to be potentially a way of separating out these patients. And that is maybe a hint as to subtyping. And so that's one example, but of course there are others, other novel therapies that look like they may respond better to other subtypes. At the same time, with the advent of immunotherapy and this immunotherapy revolution that has really altered the lives of some of our patients, we're now looking at what are some other scenarios in which we can incorporate this. And so at the top there, you see incorporating with thoracic radiation. And so this is really patients with metastatic disease where they're getting some immunotherapy, but also getting radiation for it. And this is really an effort at enacting an abscopal effect, which is really to increase some of the markers from the cancer with the radiation and then enhance an immune response that would really lead to an impact at other sites that are not radiated. And so this is a concept that is being further evaluated. At the same time, taking immunotherapy, which we know works so well in the metastatic setting, and incorporating that in the limited stage setting, where our goal is of treatment is to cure the diagnosis. And so there's an incorporation of immunotherapy with the chemoradiation as a potential way of improving in that setting. Much like what we've seen within non-small cell lung cancer, these checkpoint inhibitors initially in the second line and then first line, and then we've seen it incorporated with concurrent chemoradiation and immunotherapy, and now of course there are adjuvant and neoadjuvant studies. And within small cell lung cancer, we're really seeing this incorporated into earlier stage settings as well. And relevant to my comment earlier about PARP inhibitors, this is SWOG 1929. This is a phase 2 study of maintenance atezolizumab versus atezolizumab plus the PARP inhibitor talazoparib. And per my comment earlier as well, this is looking at Schlafen-11 positive. Now, PARP inhibitor studies in small cell lung cancer, as I've mentioned, have a hint of benefit, but really overall have been negative trials, unfortunately, in the past. But when separating out those with Schlafen-11 expression is where we're really seeing what looks like a subset that is most likely to benefit. And this study particularly separates out that population. Now, we've discussed the PARP inhibitor plus immunotherapy. This is also looking at liposomal irinotecan, and so there's data that's compelling with liposomal irinotecan, which is also well tolerated. Another one is bispecific T-cell engager, and these are drugs that really bind to DLL3 as well as binding to CD3, which is on T cells. So it's essentially pulling the immune system together with the cancer cells and creating a greater immune response. And so there's been some early data that has been quite compelling. And then CAR T is kind of next line. We don't yet have a lot of data, and this certainly CAR T is something that's being done in other cancer types and has really been an exciting technology. And so there's quite a bit more work, I think, before we really get to the point of utilizing CAR T. And there are some early studies in lung cancer, including in small cell lung cancer, but quite a bit more work to do. Now, this is going back to the bispecific T-cell engager. This is AMG 757. This is the drug that binds DLL3 as well as CD3. And I mentioned we have some early data that's quite compelling, and so we see that here with the waterfall plot there on the right. These are patients that are, we see an array of dosing. This was early studies, but a number of patients with responses. The The drug itself has been pretty well tolerated. This is something that has initially required hospitalization to really look for cytokine release syndrome. And of course, that's the toxicity to really look for. And you'll see there on the top left that toxicity mostly was cytokine release syndrome. And unfortunately, most patients that have had any degree of that have gotten over that. And so this is one of the studies, but there are other drugs also binding CD3 and DLL3. And I think we'll see more of this class with time. So now we're going to go into Module 3, parsing the practicalities, and really look at tailoring a strategy for patients. We've talked about broad data, and now we're going to kind of dive into more specific scenarios and what we would choose for individual patients and providing individualized care. That's a hard thing to really do within a broad talk, obviously. So we'll talk about clinical scenarios. So let's start with this one. 58-year-old woman with a past medical history of 60 PAC years, presenting to primary care with a 2-month history of persistent cough and generalized fatigue, performance status of 1, chest x-ray showed a left upper lung opacity, CT scan was then done, which also showed a mass, as well as hilar adenopathy. Bronchoscopy was done, showed small cell lung cancer. Fortunately, MRI of the brain was negative, and PET-CT showed only the lung mass along with the adenopathy. So fortunately, this is limited stage disease. Of course, that does require radiation oncology evaluation and consideration, but I think we can presume that this would fit within a radiation field and therefore be a treatable limited stage diagnosis. And in fact, this patient was treated with concurrent cisplatin etoposide and radiation. Now, there's one component of this case that I'm going to kind of step to the side now and discuss separately. And that really is that 60 PAC year smoking history is really just to highlight that this is a classic small cell lung cancer, or rather, if the patient did not have any smoking history, then I would treat this as a potential consideration of a non-small cell lung cancer, in which case patients should get genomic testing. Now that's particularly important in the metastatic setting with patients who have extensive stage disease. If they have no smoking history or a very limited, very distant smoking history, then it's NCCN guidelines supported, and I'd strongly recommend getting genomic testing. Within non-small cell lung cancer, we do next generation sequencing. That's a separate topic in itself, but I would strongly advocate for next generation sequencing in small cell lung cancer as well in a patient without a smoking history. And in fact, I have diagnosed patients with specific alterations that are targetable that then had responses to treatment. And in one case with a patient who later on needed a biopsy again for something, and so we biopsied the liver. And despite having initially, at the time of diagnosis, talked with pathology saying this is an odd scenario, and pathology really saying this absolutely, under the microscope, clearly looks like small cell lung cancer, that future biopsy really clearly did not look like small cell lung cancer. And so it certainly had neuroendocrine differentiation, but at that point was more of a non-small cell, in which case, in that setting, really does require genomic testing. And so that's a very important consideration. In this case, has the smoking history, small cell lung cancer, and classically looks like it, we'll just say, based upon the diagnosis. So concurrent chemoradiation does well, but unfortunately, 8 months after completing treatment, had a recurrence in liver and bones. Still a good performance status. Let's say she's asymptomatic at that time as well. So the question is, what would you recommend for this patient? And here's a list of options. Carboplatin etoposide retreatment, but including atezolizumab or Dervalumab, lurbinectedin, Topotkin, or Pembrolizumab or Nivolumab as single agents. Now this is a complicated one that actually, I think, makes for really great discussion. And in this setting, I'm giving a talk, so I'm gonna kind of play the multiple parts of that discussion. But as far as a thought process that I have, in this setting, it is 8 months. I don't really think of it in the same way as someone who's had extensive stage disease that's treated with platinum etoposide and is now 8 months. This is someone who also had radiation. Although in this setting, the recurrence really is in liver and bones, so it is in distant sites. It's not in the area that was radiated. If you have recurrence in the area that's radiated even earlier, that becomes particularly worrisome from a prognostic standpoint. But in this setting, platinum-sensitive disease based upon the time frame. So NCCN guidelines would say retreatment with platinum etoposide. At the same time, the patient never got a checkpoint inhibitor. And I will make the point that absolutely everybody who qualifies, people who, certainly there are cases where patients cannot get a checkpoint inhibitor, although I think those are quite rare actually. If they haven't gotten a checkpoint inhibitor, that should be incorporated. And so in this setting, you're really doing both of those. They're getting their platinum etoposide, they're also getting a checkpoint inhibitor. Another option would be lurbinectedin, FDA approved, second-line therapy, and certainly justifiable, generally pretty well tolerated. We've seen the data on this. The response rates, I would say, are better than what we've seen in immunotherapy alone, although the durability of those who have a response is not the same as those who have a checkpoint inhibitor alone. But is a viable option, is an approved option. Third would be Topotkin, another FDA-approved option. I will say that I tend to not use Topotkin and rather prefer irinotecan. In this setting, I don't think I would be using either of those, but if Topotkin was a consideration in my mind, I would end up using irinotecan instead. And then Pembrolizumab or Nivolumab, these are not FDA-approved options. This initially had an FDA approval, although the application for that was pulled when each of these drugs was incorporated in the first-line setting, but had studies that were negative. That being said, the curves for these drugs look similar to the ones that were approved. They narrowly missed the median cut point, which I've said I don't think is the right way of really highlighting the benefits of these drugs. And in fact, actually, Nivolumab, there was a first-line trial that in fact was positive, although that was not a registrational trial. And in either case, in this setting with more than 6 months out, if the patient tolerated platinum etoposide well, I would be more inclined to use the first regimen of platinum etoposide plus either atezolizumab or Dervalumab as really like the next first-line therapy for extensive stage disease. If the chemotherapy-free interval was shorter, if we say that this occurred 3 months after finishing concurrent chemoradiation, then the question is, well, I wouldn't really give retreatment with platinum etoposide in that setting. I wouldn't expect much from that. I think you're really just adding toxicities without benefit. But now, if you're using Pembro or Nivo, these are not FDA-approved options as single agents. If the patient has limited volume of disease, then I may consider that in this setting. Like I said, patients who really get a nice response to these drugs, they get, in some cases, really impressive durability. And so a study with pembrolizumab showed a response rate of 19%, but more than half of those patients with ongoing disease control at 2 years. Similar data with Nivolumab as a single agent, limited numbers that have a response, but amongst those who have a response, really an impressive percentage that have durability to that response. And so if I can use an analogy, I really liken this to kind of swinging for a home run. With the checkpoint inhibitor, you're swinging for the fences. And when you connect, then you can get that home run. The problem is that the majority of patients don't get that benefit. And this is where really our studies, some of the immunotherapy studies that I mentioned earlier, are really ways of trying to get that kind of home run for more patients. But unfortunately, the majority of patients don't get that benefit. So if you have somebody with more volume of disease, where you feel like they really need some kind of response to therapy, if you're using that single agent Pembro or Nivo, the majority of patients are not going to get that benefit, and unfortunately, you can lose the opportunity for any further therapy. And so this is where some of the other drugs that have a higher percentage of likelihood of response may end up being preferred as a way of trying to get some benefit to that, and then hopefully being able to use one of the checkpoint inhibitors later on down the line. Now let's talk about a different case. We're going to switch to the extensive stage setting. So we're going to presume that patients were treated initially with platinum etoposide plus a checkpoint inhibitor. This is a patient that presented with shortness of breath, ultimately had a scan showing a mass with mediastinal adenopathy, liver metastases, MRI brain, showed no evidence of disease. Patient was initially treated with carboplatin etoposide plus atezolizumab for 4 cycles, then had 8 months of maintenance atezolizumab. So chemotherapy-free interval of 8 months based upon that, before the CT scan showed new bone metastases and progression of other sites as well. So the question now is how to treat this patient with platinum-sensitive disease and a chemotherapy-free interval of 8 months. Now, if we look at FDA-approved therapies, you see on the left here, Topotkin and Lerbin are both FDA-approved therapies. If we presume that this patient had prophylactic cranial irradiation and the MRI brain at the time of recurrence shows no evidence of disease, then there's not a concern about the CNS progression. So we're talking about systemic treatment. Topotkin and Lerbin both FDA-approved. I've mentioned that for me, I would tend to use irinotecan rather than Topotkin due to tolerability. Although more recently, lurbinectedin has been the drug I've used more commonly. As I mentioned, side effect profile is quite good. Certainly neutropenia is something that you have to watch for. Although the trial, as I mentioned, did not allow for primary GCSF prophylaxis, I don't use that in everybody either, but in patients who I'm particularly concerned about neutropenia, I would then use GCSF prophylaxis. Now, if we switch this up and say that the patient at the time of recurrence has multiple brain mets, despite having previously gotten prophylactic cranial irradiation. And unfortunately, this is a challenging setting that we see. Patients who have had their brain radiated and now have brain metastatic recurrence in the brain, where trying to re-irradiate becomes a challenge. Now, we have a study here where radiation oncology will do SRS or focused radiation, but if there are multiple sites, then that really isn't feasible. And so now we're talking about how can we give them a systemic therapy that's going to work in the brain. And this is really the setting that I think temozolomide is the most compelling for. There is good CNS penetration. This drug doesn't work for everybody, but the good thing is that it is generally pretty well tolerated. And so cytopenias may occur and fatigue may occur, and these are things that I would generally watch for. But most patients really tolerate the drug without significant toxicities. And so as far as trying to get CNS control with systemic therapy, this is really probably the best option. Some of the other drugs we've discussed can also have an impact, but the crossing of the blood-brain barrier is not as significant as like what we see with temozolomide. In the setting of somebody who's gotten prophylactic cranial irradiation and has multiple new brain mets with a chemotherapy-free interval of just 1 month, that really is one of the most challenging settings, because this is very resistant, a very challenging disease. They've already been radiated. And in this setting, using temozolomide is, again, kind of the one that I would reach for as a way of trying to get CNS control. But with this kind of setting, I think the prognosis is really quite poor. And so this is somebody you'd really have to watch very closely. Now we're going to talk about a different patient. This is, you see here, Miss S, A 70-year-old woman treated with first-line platinum etoposide plus a checkpoint inhibitor, had a chemotherapy-free interval of about 6 months, and then treated with lurbinectedin. And now has some control with lurbinectedin, and then has progression after lurbinectedin, and so what would be some other treatment options for this woman. Now, we're not really diving into specifics in this case because we're discussing kind of a broad framework of what to use in the third line and beyond. And so some of my thought process. I've already highlighted quite a bit the whole CNS aspect, and so we're going to assume she does not have CNS progression, but has received a checkpoint inhibitor and clearly had progression on a checkpoint inhibitor, which means that there would be no benefit to giving other checkpoint inhibitors. After lurbinectedin, of course, there is Topotkin, which is FDA approved. I've mentioned that I would tend to use irinotecan, a preference of mine as far as tolerability. Other agents like Paclitaxel weekly has less toxicity and therefore would be an option. Temozolomide I've discussed before, but it's not what I would reach for unless there was really a CNS-specific reason to do so. So Paclitaxel can cause neuropathy. If that was something where she previously had that or that was something I was concerned about, then I would not use Paclitaxel. Irinotecan can cause diarrhea. Neither of those really end up being severe for the majority of patients. These certainly can be, but it's not that those toxicities are necessarily a big concern for me, but more so that if the patient had something that made it a concern, then maybe I would be less inclined to use it. So Paclitaxel, neuropathy, irinotecan, diarrhea, temozolomide, really I would reach for more just if there was an issue with CNS in particular. So some final takeaways in conclusion. In the first-line setting of extensive stage disease, very clearly the standard of care is platinum etoposide plus atezolizumab or Dervalumab. And this is a way of swinging for the fences, as I've described, with a checkpoint inhibitor, while also getting the chemotherapy that has a very high response rate. And this first-line setting, by including checkpoint inhibitors, we've really seen a significant impact to the tail of the curve, and that's where we're really seeing the most benefit in that setting. At the time of progression, the chemotherapy-free interval is very important as far as prognostic significance, but also if it's more than 6 months, a chemotherapy-free interval, platinum etoposide is a consideration, retreatment, and in fact is the NCCN Guidelines recommended treatment. If the chemotherapy-free interval is less than 6 months, the FDA-approved therapies are Topotkin or lurbinectedin, both of which we've discussed. We've also discussed next-line considerations of Paclitaxel, irinotecan, each as single agents. In the setting of CNS metastases that cannot be treated with radiation, certainly temozolomide is a consideration in that setting. And only in patients never previously treated with a checkpoint inhibitor should pembrolizumab or nivolumab be considered per the NCCN guidelines. At the same time, in patients with a less than 6-month chemotherapy-free interval, the NCCN guidelines also recommend consideration of clinical trial. And I would say really this is a strong consideration to make really throughout small cell lung cancer because this is such a challenging diagnosis. And so when we're second line and beyond, these patients in general have a poor prognosis, and unfortunately, the disease can be very difficult to treat. There are an array of clinical trials that are happening. We've discussed some of them, but this is really just touching on multiple new novel therapies. And hopefully, this new proposed small cell lung cancer subtyping, hopefully that will provide further a foundation upon which to really select out which patients may benefit most from some of these developing novel therapies. The ongoing research in small cell lung cancer continues to be overwhelmingly important. And with that, I thank you all for attending this, and it was a pleasure to give this talk to you.
This activity is certified by PVI, Peer Review Institute for Medical Education.